This presentation on mechanical ventilation and nursing considerations is going to build off of your knowledge of mechanical ventilation, respiratory failure, and acid-base balance. So we're going to consider what the nurse is responsible for in caring for the mechanically ventilated patient. So as we discussed before, mechanically ventilated patients are at risk for a number of complications upon intubation. However, we need to also think about patients who've been intubated for a longer period of time. So we kind of draw this line at 3 days, considering anything longer than 3 days to be long-term mechanical ventilation. Notice I'm not using the word chronic. We're talking about long-term mechanical ventilation. Now, 3 days might seem like a short amount of time, but think about it for a second. Being sedated with a tube bypassing your normal airway for 3 entire days, your risk for complications will start to increase. So we talked about how there is this risk for right mainstem bronchus intubation upon initially intubating somebody, but why is it a risk for prolonged intubation? So remember, these tubes can move or migrate, and they can slip out of place as the patient moves over time as tape loosens. So the tube could migrate down past the carina and potentially slip into the easiest place, which is the right mainstem. So this is why many hospitals have a protocol of a daily chest x-ray to make sure the endotracheal tube is in the right spot and it's not migrating. So additionally, after being in the trachea for so long, our patients are also more likely to suffer damage to the trachea, to the larynx, or inside their mouth and their nose. Now, your patients are also at risk for suffering what's called oxygen toxicity. And yes, we can have too much of a good thing. When the partial pressure, or the amount of oxygen in our bloodstream, gets too high, your patient develops what's called hyperoxia. So we're more used to saying hypoxia, but there is this thing called hyperoxia. And this is when your patient experiences a large amount of reactive oxygen. And these reactive oxygen begin to cause pulmonary toxicity, and they can cause damage to the lining in the alveoli. So now you can kind of think back to when we talked about ventilator settings and FiO2 and PEEP. This is why if our patient has an FiO2 of 50% or higher, but they're not oxygenating well, we look at increasing PEEP instead of just cranking up that FiO2, which could put our patients at risk for oxygen toxicity. So as you can imagine, mechanical ventilators are changing our respiratory rate and our ability to exchange oxygen and carbon dioxide, as well as our patients' metabolic needs, how hard they're working, right? So if our ventilator isn't helping the patient enough and they're having a really hard time breathing, their metabolic needs are going to go up. So the patient's ABG could definitely be impacted. Now, the next thing we need to talk about is stress. Being on the ventilator is stressful. And we've talked about how being in the ICU in general is stressful. So our patients are at risk for anxiety, potentially depression, psychological distress, and additionally, this stress paired with the impaired splanchnic perfusion to the stomach and mucosal damage and other factors, our patients are also placed at risk for peptic ulcer disease. Now, another risk factor to consider in these long-term ventilated patients is hemodynamic compromise. Why? We're talking about the lungs, not the heart. But remember, we are not using the normal negative pressure ventilation we're used to. We're using positive pressure ventilation. We're pushing air into somebody's lungs. So you might recall that every time we give a patient a breath, we increase the intrathoracic pressure. So think about it. What else is in that intrathoracic cavity besides the lungs? It's the heart. So when we increase pressure to inflate the lungs, we increase the pressure up against the heart and around the heart. Now, a little bit of pressure might be okay, but what if we had to turn up the PEEP for a patient, let's say up to 20 centimeters water? This patient's really, really sick. That's a lot of constant pressure in the intrathoracic cavity. And that's basically counter pressure on the heart that is trying to fill up before it contracts. But it's pretty hard for that heart to fill up if something is squishing it against it and if something is pushing it down. So therefore, if your heart can't fill up because it has that pressure, maybe that 20 centimeters water of PEEP pushing against it, it can't fill up. It's not going to pump out very much blood either. So what do we see? We see a lower cardiac output and a lower blood pressure. So you can start to see how complicated this can get and how important it is to get our patients off the ventilator as soon as it's appropriate. Now, one unfortunately fairly common complication of long-term mechanical ventilation is VAP, or ventilator-associated pneumonia. Now, this is basically a pneumonia that occurs 48 hours or later after an endotracheal tube has been placed. Now, why does this happen? Well, normally without an endotracheal tube, we have all of these defenses in our respiratory system, for example, our cilia. But when an endotracheal tube is placed, we bypass all of those defenses. So if a patient starts to develop a fever, they have foul smelling or purulent sputum, they have an elevated white blood cell count, you hear crackles or rhonchi in their lungs, and they're on the ventilator, that patient needs to have a sputum sample sent down to the lab, or their chest x-ray needs to be reviewed. This patient could be developing VAP. So what do we do for patients who have VAP? Now, we want to avoid any aspiration, so our patients should be sitting up at 30 to 45 degrees, and each hospital will have a policy for which level of 30 or 45 a patient should be sitting up at, because we have to consider when someone is sitting up, that puts more pressure and more weight on their coccyx. So do we want to prevent pneumonia, or do we want to prevent decubitus ulcers on the coccyx? So this you can see how this can get pretty tricky. We don't want to choose just one. We want to kind of find a balance between both of these. And obviously, anytime we want to prevent any type of infection, hand washing is key. You could have just been caring for somebody with resistant Pseudomonas and then walked into your patient's room. So excellent, thorough hand washing in the ICU is essential in reducing the risk for passing those germs around and causing VAP. And then something you may have heard of already is called the VAP bundle. And this is basically a group or a bundle of interventions that are geared toward a goal. So a VAP bundle includes specific interventions to reduce ventilator-associated pneumonia. And most commonly, this includes elevating the head of the bed to either 30 or 45 degrees, providing the patient a daily break from sedation, and that'll increase their neurological stimulation, possibly exercise their breathing muscles. This is often called a sedation vacation. You will also see peptic ulcer disease prophylaxis and DVT prophylaxis in this bundle, and many hospitals incorporate meticulous oral care into the bundle and also a daily assessment of the patient's readiness to extubate. So as we think about what it's like for a patient to be intubated and what our nursing responsibilities are, remember that this patient is likely sedated and we've bypassed their normal respiratory anatomy and physiology, and they are already sick. They were placed on a ventilator. So one of our roles is keeping this tube, this endotracheal tube, patent, and sometimes it's a tracheostomy. And our patient may not be awake enough or strong enough to effectively cough up secretions, or those secretions may be so thick or so copious that they need help clearing them. So this is where suctioning comes in. And now what you are most likely to see for a patient with an endotracheal tube in the ICU is what's called closed sterile suctioning or closed inline suctioning. And this is a way for the nurse to suction the patient with a sterile catheter while the patient is on the mechanical ventilator. However, you'll also see open sterile suctioning, which is most commonly used for a patient with a tracheostomy who's not on a ventilator, but it can also be used for a patient who has no artificial airway, where we suction through the nares, or a patient who is on the ventilator, but this closed suctioning system is not enough, and we actually have to end up disconnecting them from the ventilator and using this open sterile suctioning. However, that's not quite as common. So when do we suction? And the key thing to remember about suctioning is that it's stressful for the patient. Yes, we're helping them clear their airway and keep their endotracheal tube patent, but the thing to think about is what it must feel like to be suctioned. So we should only be suctioning when it's indicated, not on a routine schedule, not every 2 hours, not every 4 hours, not just because. We should be suctioning when it's indicated. So when is it indicated? When is this? Well, a few obvious examples would be when the patient is coughing already, but they're not able to clear their airway completely. Or maybe we hear stuff in their lungs, we hear rhonchi or crackles. Or maybe we see a patient desaturating and suspect that there are secretions impairing their ability to take in oxygen. And we may actually be able to visualize or hear a large amount of secretions in the endotracheal tube. So we talked about why we only suction when it's indicated, and here is why. There are all of these complications that could potentially arise when we suction a patient. So specifically, hypoxia might be notable. While we may be clearing the airway and we are trying to help our patient oxygenate better, we could have just interfered with their oxygen supply and potentially their ventilation. So therefore, it's really common to hyperoxygenate, and sometimes even in the hospital protocol to hyperoxygenate a patient before suctioning. And all this involves is turning up the FiO2 setting up to 100% temporarily before suctioning, and then letting the FiO2 setting go back down to the previous setting afterward. So pause the slide for a second and take a look at some of these. Think about why these may happen. Is it due to stress? Are we interrupting someone's oxygen supply? Are we irritating tissues? So go ahead and pause the presentation and take a few seconds to review these. So not only do we need to think about how to manage a normally functioning ventilator and endotracheal tube, but we need to know what to do if things go wrong unexpectedly. For example, if the ventilator malfunctions, it may alarm, it may stop working, the patient's saturations may drop rapidly, you may hear nothing, but you'll notice a dramatic change in your patient. And the bottom line is when you walk into the room and notice that the ventilator is not working appropriately, if your patient is stable and the malfunction is not immediately life-threatening, you can take a couple of seconds to quickly make sure all of the settings are appropriate and maybe quickly fix an error. But if there is no immediate solution available, it's time to stop trying to fix the machine and start looking at your patient. You are now the ventilator. So remember, airway and breathing are our priorities, not technology support. So while this won't happen very often, and hopefully it will never happen to you, it's important to remember what our priorities are in this type of emergency. If the ventilator won't work, stop fiddling with it and breathe for your patient. So how is this done? So you can see here there's an ambu bag or the bag valve mask, and notice we have the blue bag that you can squeeze to deliver the breath. But what else do you see? Oxygen tubing. We do not want to just ventilate these patients with room air. We need to hook the ambu bag or the bag valve mask up to oxygen in the patient's room and then bag them. Now you might notice another dilemma here. The ambu bag has a mask for a face and a mouth, and our patient has an endotracheal tube. They were just on a ventilator that malfunctioned. So that mask is not going to fit their face. Well, fortunately, the ambu bag comes with a detachable mask. So when the mask is on, it may look like this. And then when you pull the mask off, now you can attach the ambu bag directly to your patient's endotracheal tube or tracheostomy. So once you have the ambu bag on your patient's endotracheal tube, you are now providing breaths for them. You should be asking for help now that you have your airway secured and you are ventilating for your patient. And unless you plan to stand in their room for 12 hours ventilating them and acting as the mechanical ventilator, you need a plan. So you'll likely call the respiratory therapist and request a new mechanical ventilator if you're concerned that the one you have is malfunctioning. So in addition to maintaining this artificial airway and considering what we might need to do in case of an emergency, we should also be thinking about what medication these patients will be receiving. So for example, it's very common for a patient on the mechanical ventilator to be sedated. As you can imagine, it's very uncomfortable to have a large tube down your throat and have a machine forcing air through that tube into your lungs. So a sedative such as propofol, midazolam or Versed, dexmedetomidine or Precedex, any of these might be used in your ventilated patients to sedate them. Now, additionally, it's also common for these patients to be experiencing pain while they're on the ventilator. Maybe they're having pain for another reason that they're in the ICU as well. So therefore, an analgesic such as fentanyl or morphine may also be present. And both of these, your sedation and your analgesic, will be on a continuous drip, most likely. So the other medication type we haven't really discussed yet is called a neuromuscular blocking agent. And basically, we are causing neuromuscular blockade or paralysis. So common neuromuscular blocking agents can include pancuronium, vecuronium, rocuronium, and neostigmine. So why? Why would we paralyze a patient on a ventilator? Well, sometimes a patient is so sick, for instance, let's say they have ARDS. We do not want them to do any breathing on their own. We want them to let the ventilator do all of the work. And even sedating them is not enough to prevent them from breathing on their own or fighting the ventilator. So we're watching their oxygenation drop, we're watching them become hypoxic. We can't sedate them anymore, but they're not letting the ventilator work. Maybe we're seeing these high pressure alarms. So in those severe cases, we may choose to paralyze the patient. However, one of the most important things to remember when we paralyze someone is that is all the medication does. They can't move a muscle, but they're wide awake. They can feel everything. So you could see how cruel it could be to paralyze someone but not provide any sedation or pain control. So therefore, it's so important to provide sedation at the very least for patients who are paralyzed. Otherwise, this could be a terrifying experience. So here's something else to think about. Yes, we may need to paralyze a patient with a neuromuscular blocking agent like pancuronium, but this is an IV drip, just like fentanyl, just like Versed, just like propofol. It's constantly going into your patient. And just like fentanyl, just like Versed, just like propofol, it needs to be titrated according to your patient's response. We don't want to oversedate a patient, and we don't want to give them too much of an opioid, and we don't want to over-paralyze them either. But how do we measure how much someone is paralyzed? We can't use the pain scale. We can't use the Ramsey scale. We can't even look for how they respond to pain. They're paralyzed. Well, in order to see if we are appropriately paralyzing a patient, we use something called train of 4. And basically, this involves delivering an electrical impulse to the nerves and seeing what the muscular response is. We want to see how well the nerves are communicating with the muscles. Remember, we gave a neuromuscular blocking agent. So are we completely blocking everything way too much? Are we not blocking enough, or is it just right? So this train of 4 machine consists of a small box, also known as a nerve stimulator. And it has a few buttons and a couple of wires that will eventually deliver electrical impulses. And sometimes it'll have another wire with a sensing device connected to it. So different models may differ slightly, but on each neurostimulator device, you will see a way to turn up or turn down the amount of electricity in milliamps. And that's the amount of electricity that the neurostimulator will deliver. There will also be a TOF button, or train of 4 button. Now, let's say you want to see how paralyzed your patient is that's on a vecuronium drip, for instance. So first, you would place electrodes, the same ones that you would use for an EKG. You place them along your patient's ulnar nerve. And you may also see these electrodes placed along the face by the temporal nerve. Next, you connect the 2 wires from the neurostimulator device to those 2 electrodes. And you can see that here. Some train of 4 devices will also have you set up a sensing connector as well, but we're going to focus on the 2 wires that are connected to the electrodes. So once your patient is connected to that neurostimulator device, you would then turn up the desired milliamps, usually starting at a low rate, maybe around 10, and then hit the train of 4 button, or that TOF button. Now this would result in your device delivering 4 quick impulses at 10 milliamps, or maybe you turned it to 30, so at 30 milliamps for 4 impulses. And you would watch your patient's hand right by the thumb to look for a muscular response or a twitch. And this is usually quite subtle. So if someone's hand twitches 4 times after receiving that train of 4, those 4 impulses, all of those impulses got through and communicated to the muscle. Therefore, we are not blockading their neuromuscular junctions as well as we should. They're not truly 100% paralyzed. They might be a little paralyzed, but not as much as we would like in the ICU. Now, let's say we deliver 4 impulses by hitting that train of 4, or that TOF button, and we see no twitches in their hand. So you turn up the milliamps a little bit. Maybe we go up to 40 milliamps. We look at their hand again, hit the TOF button, no twitches. You turn it up again, maybe all the way up to 100 milliamps. Still no twitches in their hand. This patient is completely paralyzed. We have 100% neuromuscular blockade. So you can see we want a happy medium. We don't want 4 twitches so all the signals get through when we hit that TOF button. But we don't want 0 twitches either. We don't want them 100% paralyzed. So therefore, when we use the TOF button, when we use the train 4, we want to see 2 twitches in response to getting those 4 impulses from a device. So in a sense, when you think about this, if you see more twitches, that means more signal went through and we are not blockading enough. Less twitches, less signal went through, we are blockading more. So when you think about the interaction of your train 4 and your pancuronium, for instance, if we see too many twitches, we need to block more by turning up the pancuronium. If we don't see enough twitches, like no twitches, now we need to back off because we're blocking too much. So we need to turn down the pancuronium. So let's take a quiz. Your patient has just been intubated with the diagnosis of ARDS. You recognize the following is true about suctioning. 1, suctioning is used purely for patient comfort. 2, suctioning should be done Q2 hours on schedule. 3, suctioning is appropriate when the patient is showing signs of hypoxia or copious secretions. And 4, patients on a mechanical ventilator should be able to cough up all of their own secretions. Suctioning is only for an emergency. Pause the presentation and consider your answer. The correct answer is 3. Remember, this is actually very uncomfortable when we suction our patients, and we don't want to routinely suction without assessing whether that patient needs suctioning. And also, while suctioning may likely occur during an emergency, it is also for when a patient is just coughing but not able to clear their airway. So our next question. You're taking care of a 61-year-old male who is receiving pancuronium, fentanyl, and propofol while on the ventilator. You walk in the room, and the patient's blood pressure is 200/130, the heart rate is 154, and the patient is diaphoretic. You look at the ventilator screen and see no issues, and you see the patient's oxygen saturations are 98%. What's the most appropriate nursing action? 1, turn up the pancuronium. 2, turn down the pancuronium. 3, turn up the propofol. 4, turn down the propofol. Pause the presentation and consider your answer. The correct answer would be turning up the propofol, or 3. Now, why is this? Look at those vital signs. Your patient is having a sympathetic response. He's panicking. Why would someone in this situation be panicking with that blood pressure of 200/130 and that heart rate of 154 and they're diaphoretic? So it's likely that he is paralyzed but too awake. So imagine being trapped in your body and unable to move at all. So he may not even be aware of what's going on. So this could be terrifying for him. Increasing his sedation is a key humane comfort measure in this case. Now, it's very challenging to assess the level of sedation in a patient who is paralyzed. Remember, we can't look at their anxious face. We can't see them trying to get our attention. They can't move. We can't use the RAS scale. We can't use Ramsey scale on our paralyzed patients. But they can still respond with this type of response with a high blood pressure and a high heart rate from all this anxiety. Now, we don't want to wait for our patients to become hypertensive and tachycardic to know that they're not sedated enough. So we can use other devices to assess how sedated our paralyzed patients are. And we actually attach little sensors to the patient's forehead. It's called a BIS monitor. And we can actually detect brainwave activity to estimate their level of sedation. A 61-year-old male is receiving pancuronium, fentanyl, and propofol while on the ventilator. You assess the patient's train 4, and you see the patient's hand twitch 4 times. Which of the following is the most appropriate nursing action? 1, turn down the pancuronium. 2, turn up the pancuronium. 3, turn off the pancuronium. Or 4, leave the pancuronium at this rate. Pause the presentation and consider your answer. The correct answer is 2, turn up the pancuronium. So remember, just like fentanyl and propofol, neuromuscular blockers should be titrated according to the patient's response. So remember, the purpose of pancuronium is to paralyze our patient. We want them to be appropriately paralyzed by showing us 2 twitches in response to receiving 4 impulses from the train 4. However, this patient has just twitched in response to all of the impulses 4 times. So he is not paralyzed enough, and therefore our drug is not doing enough of its job, and we need to titrate the pancuronium up according to the protocol. Now, another key concept for you to consider with mechanically ventilated patients is how we monitor them. So we discussed this in class a little bit, how checking the patient's respiratory rate and oxygen saturation and tidal volumes and peak inspiratory pressures will tell us how our patient is working with the ventilator. But we also talked about how ABGs are important to monitor. So let's take a look at what we can do with the ventilator settings according to what their ABG looks like. So, if a patient is in respiratory acidosis, that means that they are retaining too much carbon dioxide. So they are not breathing out enough CO2. They're not exhaling enough CO2 efficiently. Therefore, we need to turn up the rate of respirations on the ventilator settings. We could also consider increasing the PEEP, which, as you recall, will facilitate gas exchange. And remember, CO2 is involved in gas exchange. But the bottom line is we need to get the CO2 out. So the most common intervention is increasing the respiratory rate setting on the ventilator. Now, if we see respiratory alkalosis, we have the opposite problem. So we're getting rid of too much CO2. So the most common way to address this is to reduce the respiratory rate setting on the ventilator. We need to retain more carbon dioxide. Now remember, it's not just respiratory acidosis or respiratory alkalosis that we're worried about. Remember, your ABG also provides you with a PaO2, that partial pressure of oxygen in the blood, measured in millimeters mercury. Remember, this is different than oxygen saturation, so we can have a PaO2 of 110 millimeters mercury. Now, our normal range is 80 to 100 millimeters mercury, so if our PaO2 is below 80 and we are hypoxic, we need to take a look at the bigger picture. If we can avoid turning up the FiO2, that's ideal. Remember, we want to avoid oxygen toxicity, so we may need to increase the respiratory rate if the rest of our ABG indicates that that would be appropriate. We may need to increase the tidal volume or the pressure support settings, again, if the rest of our ABG indicates that that's appropriate. We may need to increase PEEP, and yes, we may need to increase the FiO2. It's not bad to increase our FiO2 if that's what's indicated, and we're working on other alternatives. Just keep in mind that there are other ways to increase our patient's oxygenation. Now, as mentioned before, our patients can get hyperoxic, and their PaO2 can go above 100 millimeters mercury. So in this case, we often think in the reverse. We want to get that FiO2 down when it's appropriate. So this is typically the first thing you would do if your patient is hyperoxic. But if your patient is also in respiratory alkalosis, which could very easily happen, think about that. You're breathing really deep and fast. So you're getting lots of oxygen in and also blowing off lots of CO2. So we may want to turn down their respiratory rate or their tidal volume or their pressure support. We may want to sedate them more. They may even need their PEEP decreased. However, remember, our first move is to see if we can get that FiO2 setting turned down. So let's look at a final question. Here we have a 55-year-old female with pneumonia, and she's on the ventilator. Her ventilator mode is SIMV. And her settings are a respiratory rate of 8, a tidal volume of 400, an FiO2 of 40%, and a PEEP of 5. So she's on these settings in this SIMV mode, and you draw her ABG, and it shows a pH of 7.23, a CO2 of 66, a bicarb of 14, and a PaO2 of 69. So pause the presentation for a second and think about which of these following options is the best appropriate nursing action. So the correct answer is 2. We need to increase the respiratory rate, increase the FiO2, and increase the tidal volume. We have a patient who is in pretty serious mixed acidosis. So not only is she retaining CO2, she's also working pretty hard in some anaerobic metabolism, it looks like, causing some metabolic acidosis as well as respiratory acidosis. So we need to help her out a little bit more, and we need her to breathe faster and deeper. So we can rule out number 1 and number 4, which don't address this. And we notice that the patient's PaO2 is low, so she needs better oxygenation. So increasing the FiO2 and tidal volume would be appropriate actions there. Now remember, SIMV is going to deliver, in this case, 8 breaths guaranteed with a volume of 400. So if she takes a 9th breath, she can, but she is going to have to determine the volume of that breath. She could take a 9th breath with a tidal volume of 50, and that's fine, that she's allowed to do that in SIMV. So one of the issues with SIMV is if a patient is not strong enough and is not mentally intact enough to trigger their own breaths and strong enough to take deep enough breaths, and we are not helping them out enough, we're only helping her with 8 breaths a minute, this patient could very easily develop respiratory acidosis and really some metabolic acidosis because she's working really hard and she's starting to produce more lactic acid potentially. So remember, in SIMV, this is often a weaning mode because we only give them a set number of breaths and the rest is up to them. So when we increase the respiratory rate to 12, we're now helping her out a little bit more and we're increasing the tidal volume, helping her ventilate more because we have some hypercapnia here and we need to get rid of that CO2. So ventilating more with bigger and more frequent breaths is going to help with that acidosis.